Thank you for the opportunity to be here this afternoon. I hope to make this conversation a little bit informal and would encourage anybody that has questions to kind of bring them forward as we go along. This is my data. Remember it, memorize it. No. We present a poster here at this conference. Many of you may have seen it, many of you may not. We have copies of that data for you before you leave today, if you'd like to have a copy of it to review. In our analysis, what we did is we did a cross-comparison analysis between the main leaders, the three leaders in sort of risk assessment models that are genomically based with Oncotype, MammaPrint, and MammaStrat. MammaStrat is more of a pathology-based immunohistochemical staining process that is used by the pathologist to do risk stratification. Basically, we had done a series of patients with MammaPrint, and we went back and asked them at Genomic Health if they would rerun any samples that had not had Oncotype done, as with MammaStrat. And they graciously participated in the study with us to see if we could see what the concordance between the studies was, the discordance potentially, and potentially any synergies that came out of the information that was derived from this study. It included a total of 148 patients that met all of the criteria for the study, which were basically ER-positive, node-negative patients who presented with breast cancer as their primary diagnosis. I think one of the things in our original publication of this information was at the San Antonio Breast Conference just a few weeks ago, and we had the data on blueprint subtyping, but it wasn't initially available on all of the testing of all the patients. We had to ask Agendia to go back and rerun that, because as we started doing this, actually blueprint was not available. So that's how long we've been using MammaPrint as a stratifying process in our patients. So we had them do that, and we kind of acceded to the request of the Genomic Health people not to include it initially because it hadn't been available since the outset. And so it was not included. But subsequently, we had all that data, and so right at the end of that presentation, we actually reformatted this to include the subtyping information. And subtyping is important and is one of the NCCN guidelines, as also one of the St. Gallen guidelines in terms of a risk stratification modeling process with Chuck Peru's data. And to kind of answer the questions, does MammaPrint's blueprint, is it equivalent basically to the Peru data? This slide kind of demonstrates a 92% correlation between MammaPrint and basically the Peru data for subtyping. This is even probably a better demonstration of that with the, again, the red and the black representing the MammaPrint evaluation for the Peru designations of luminal A, luminal B versus the Peru designation, which is the green and the blue. And so you can see there's little, if any, significant difference between these two analytic models. One, using the original Peru data versus the MammaPrint subtyping and classification with the 80 gene profile they use in Blueprint combined with MammaPrint as a risk stratifier to put them into luminal A or luminal B. So it's got pretty tight correlation between what's known, what's available, and what can be done. And as yet, along with maybe PAM50, which our other discussant will talk about, are basically the only methods available for doing subtyping available commercially to you with your patients. So from our perspective, the subtyping piece was a better thing. Since most of you here are surgeons, as was demonstrated here, I kind of compare this to sentinel node. That's my baby. I taught most of you how to do it, and I know how to do that. So I can relate it back in that context. It's sort of like if you can use blue dye or you can use radiocolloid. They work effectively well, either one independently of the other, but when, as we showed, you combine the two, it's a little more efficient, a little more effective, and quicker to your learning curve. And so the reality is this is kind of by adding two discriminators like subtyping and MammaPrint, all of a sudden now you have a better discriminator that gets you more information and may help you in your analysis of your patient care a little bit easier. So we engaged a group of 3 pathologists who wanted to be able to maintain. I think if I were a pathologist, I'd be kind of running scared with all of these genomic tests because they're so powerful and so efficient and effective and can be done so objectively without lots of variables in terms of interpretation. And so their concern was, is my interpretive skill really as good as any of this genomic information, and can I correlate it backwards to show that my interpretive skills are as good as, or will help or aid or abet this whole process. So again, that's, that was their desire and ours as well. And so they looked at a molecular subtyping by comparing it with IHC in fish. They looked at Ki67, tubule formation, nuclear grade, mitotic activity, and histologic grade. And it's very interesting how those things that are the standards that have been used, I guess, now for the last 50 years, how we then go forward with that information. Can we still use a technology that basically is looking at your eyes and your subjective impression? You know, pardon me if you're a pathologist here, but you know, pathology is not an exact science. It's basically your interpretation of what you're seeing, and it's and there are variances from pathologist to pathologist. That's why we did a threefold analysis, and that took a lot of effort. I'm telling you. So the reality here is when we broke this down, looking at the descriptors of luminal A and luminal B subtypes relative to MammaPrint, and then compared that to Oncotype DX and MammaStrat, we saw that in the luminal A category, as Peru would define it, and as MammaPrint detected it, we saw categorizations that were pretty consistent with basically these patients with most of the patients by most of the testing was low risk. There were some intermediates. There's questionably some high ones here, and so I would kind of not be able to really understand that well, at least the highs. But representatively, that's a fairly low proportion of either of these two studies. When you get into luminal Bs, that's where it all kind of falls apart, because all the tests are probably showing the same low, high, and intermediate, and they're pretty evenly divided. And so that becomes a little more problematic. From my point of view, you've got to remember that Oncotype and MammaStrat were developed in the same subset or the same set of patients. The tests were looked at in the NSABP trials that were the same trial, which basically I could answer why the patients could be low in this category, because they're already treated when they're reviewed. So they could have been at high risk for MammaPrint, but in final treatment after adjuvant hormonal therapy, be converted or downregulated to low risk patients. So that's explainable, and these would all sort of fall into the high risk. So if you take all these as high risks relative to this high risk number, they're few, but there's still some, and it may be explained by the treatment differences. So you're looking really with all these tests, MammaPrint and MammaStrat and Oncotype. You're kind of looking at Oncotype and MammaStrat together and MammaPrint separate, kind of apples and oranges, because one group is based on treated patients for outcomes analysis, and the other group is on untreated patients for outcome analysis. And interestingly enough, there were a few HER2 and basal types that were actually ER positive and fit into the study, but all of them by all tests were high risk. Okay, so again, that's pretty concordant information. So the discordance that came out of this is that patients classified as high risk by MammaPrint, 33% were classified low risk by Oncotype, and 32% were classified low risk by MammaStrat. Again, the high risk here and the low risk there could be explained by the treatment difference between the two methodologies. So that, to me, makes sense. The classification of low risk by MammaPrint, where we see classified as intermediate and high risk by these other methodologies, is a little problematic and maybe just measuring different genes and different outcomes. And our next discussion will kind of go over some of that as well with you. Again, the other conclusion we came to is that molecular subtyping significantly correlated with routine pathologic characteristics like nuclear grade, mitotic activity, and overall histologic grade. So indeed, these things do share commonality, and the pathologists are probably not out of business. Okay? So good news for them. So most of the discordant cases from the study are classified as luminal B, or this high-risk MammaPrint group. And that's really the patients that we're most concerned about that we see. Low risk by most of these tests are low risk, and the patients who are, and probably in the luminal A category. The patients who are luminal B, which are high risk but luminal types, again, there was discordance in that group as we saw. All cases classified as basal or HER2 types were all high-risk patients on all studies. So that's a nice piece as well to glean from all of this. And again, since the three assays sometimes classify risk of distant recurrence discordantly, their clinical use might lead to different treatment decisions, obviously. And that's why you're all sitting here, because that's the problem you face every day. But again, the discordant data and predictive models can affect these decisions, but the comparative validations, again, require further study. So from my point of view, I think it's an exciting area of information. There's lots of new data that's coming forward. I think the science is good in terms of the fact that you're looking at gene expression in these tumors with double testing of the genes each time they're analyzed, and I think we're going to see some dramatic new information come out within probably the next 2 to 3 years. The nice thing about genomic testing is that once a discovery is made, if you have the genomic testing in the bank, so to speak, if you have that information already performed, you can go back and reapply a new signature to the same information again. So now the era of doing a study, waiting for 5 years to get the results, and then having to validate that with another 5-year study, and then saying, okay, yeah, it works, is pretty much gone. Because now you can do a study, have the genes from the first study, go back, apply the genomic sequence you've come up with, and actually maybe be able to answer those questions with validation in already treated patients. So to me, genomic information is the wave of the future. It's the wave of drug discovery. It's, in my estimation, some things we're doing in our own laboratory, the way of defining further who's going to get the best chemotherapy and personalized medical health care, who's going to get the best radiation therapy. We're even investigating being able to develop little tumoroids and be able to treat those and do drug discovery with them, using genomic testing to predetermine which chemotherapy drugs would work the best. I'm very excited about this field, and I'm very excited about where it's heading and the direction it's going and what will be accomplished by it.